But I do want to welcome you to our Benefits Blueprint. That's the name of our podcast, and our mission is really just to have conversations with specialists in their fields to really bring a light to what's happening with our healthcare system. So today we are joined by Nurse Deb. She is the founder of AIM. Nurse Deb, I mean, you and I have had a few conversations, but if you could just take a minute just to introduce yourself, introduce AIM. What's your mission? Why are you doing this? Like, how does this bring you energy?
Yeah,
How's that?
absolutely. Thanks for having me.
Sure.
I'm a registered nurse. I'm the president and founder of AIM. That's just a fancy way of saying I get the pleasure of leading a team of nurses and doctors.
Yeah.
And what we do is come alongside patients primarily telephonically, although there's a ton of technology and that's all fine and good. But let's all face it, the people that are driving our claims and falling apart are over 40, so they're not turned into an app, right? They still want to have a phone call.
Hey, wait a second.
Right? I resemble that remark.
That was close to home.
Right? But we kind of handhold them, through the two most cumbersome ecosystems in the universe. The healthcare system, by the way, there's not a whole lot of health or much care in the healthcare system these days. But getting them the best care from the best providers, following the evidence, following the science, and the health plan system. Oh my Lord, how do I avoid becoming one of the 64% of Americans who filed bankruptcy because of medical debt,
Right.
right? Because those two travel hand in hand. The clinical and the financial are married, right? And it's one of those marriages where you can't get divorced.
So,
They're
are you saying
together.
that these two factors of our delivery system are not aligned for the best
Um,
outcomes?
Not only are they not, well, I, don't call me a conspiracy theorist on your podcast, Peter, but
Hey,
um,
I didn't have to. You just did.
right? I think they're probably more aligned than what the general person would think. The problem is they're aligned against the patient and the employer who sponsors the health plan.
But isn't the hospitals and the insurance companies, aren't they supposed to keep each other in check? Isn't the hospital out there voting and, kind of beating the cost down just because that's what the delivery of insurance is for?
You live in a land of delusion.
Come on. I'm trying to set you up.
Does it?
Nice try. No, I mean, hospitals and health systems are businesses. They operate as a business. Don't get me started on the 501(r) nonprofit
Oh,
340.
I might start you on that.
Yeah,
My
yeah,
head
yeah.
went straight there.
Yeah, not only are they businesses, but they're highly advantaged businesses.
Yeah.
And they're the largest employer of physicians. So, independent physicians don't exist anymore. 74% of physicians their practices are owned by a hospital or a health system. So even though those that are delivering hands-on care love patients and want to take good care of them and want to do all those things, they're employees of a business. So they have the constraints and, problems that go along with that.
Yeah.
The largest employer outside of hospitals and health systems for physicians is, want to guess? United Healthcare.
Yeah.
So insurance companies, God love healthcare reform and PPACA or whatever name you want to call it by, but that whole MLR ratio provision just really shot us all in the derriere. If you remember when we were going through all of that, insurance companies were very anti-reform, anti-reform,
Hmm.
anti-reform, and then like overnight, all of a sudden, like they're like, "Oh yeah, we love it. Let's do
Yeah.
it." Remember that?
Yeah. They are the
It-
distribution system for sure. And
it's
then in
because,
United Healthcare stock went like that,
yeah,
right? Elevance, is that their new name? Blue Cross Anthem. They went like that.
yeah,
Cigna
right,
went like that.
right. Besides being a nurse, my master's is in business with a minor in math and statistics.
Oh, wow.
So the minute that MLR ratio provision was being floated, I'm like, stop,
Yeah.
pause. Because if you tell an insurance company that you're going to cap their profit margin at 20%,
Yep.
It doesn't take but about 2 seconds to figure out that 20% of $100 is a lot less money than 20% of $100 bajillion.
Right.
And so anybody who actually understood healthcare and how healthcare generates a claim and how a claim gets processed knew that overnight you pushed the hospitals and the insurance carriers into bed with one another. They are both now incentivized for the cost of care to go up. The
Right.
healthcare provider, because they're a business, the health insurance company, because the more that the claims go up, the more justification they have for raising premium. And they can live quite happily on 20% of $100 bajillion.
Right.
Right? So the intention was good. It's the law of unintended consequences.
Yeah.
Where it
It
cap-
always is though. But there's also incentives. I mean, everybody that got a pass from the ACA were pretty sizable donors to the system.
Now
So
who's the conspiracy theorist?
I know. So can you, while we're on this topic, can you kind of dig into how fee for service in our system kind of plays into the cost and delivery of healthcare? Because I'm
Sure.
also then want to bridge it over into quality. So you can kind of see the track I'm going down.
Yeah. Well, if you want to talk about the fee for service healthcare system, I would say let's not talk about healthcare. Let's talk about Jiffy Lube. You ever taken your
Okay.
car there to get your oil changed?
Well, my car's electric, so no.
Cheater. Jiffy Lube, you take your car in there to get the oil changed. They do that wonderful service,
Yeah.
that little
For like
add-on for
$9,
free.
right? Or whatever.
No,
I
no.
don't know the cost of an oil change. Maybe it's 19.99 by now.
Yeah, but I mean, beyond that, they give you the free 29-point inspection.
Yeah.
Mhm.
So they can sell you wiper blades at a 25x markup and
Yeah.
a light bulb
Air
for your tail light,
filters.
$1,000, and
Yeah.
whatever. That is US healthcare fee for service system, right? No doctor gets paid for keeping you healthy.
Right.
If you don't show up in their office,
Right.
they don't get paid. So we don't have a healthcare system in the US. We have a sick care system.
That's
We
fair.
pay to treat sick patients. We don't pay to keep people healthy. That's a problem, right? That's just a fundamental flaw. The other flaw is, and this is how I take the deck and stack it in the patient and the employer's advantage, right? Do you want to be the casino or do you want to be the gambler? You want to be the casino,
Really
right?
good, for sure.
So if I know that about fee for service, let me ask you this, David. Let's say you are a world renowned ologist surgeon, right? You operate on the ologist every day, all day long. And you have phenomenal outcomes. You have low readmission rates. You have low infection rates. Your morbidity and mortality stats show you are the man when it comes to treating ologists, right? Pete, on the other hand, is an okay ologist surgeon. And a lot of his people have infections. A fair amount of them end up having a readmission. Instead of them being healed after the surgery and a 3-week recovery period, it takes them 90 days to get recovered. And a lot of them end up having to go get physical therapy and yada, 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 yada. Now, if I'm the CEO of a hospital, which one of you two am I going to promote?
The question's to David.
Oh, that's sad to even think about.
It's the Surgery Center of Oklahoma commentary all day long.
Right? I'm going to promote Pete because Pete's bringing in more revenue
More
because
patients.
under fee for service, we get paid to operate on his patients. We get paid to treat the infection. We get paid for the readmission. We get paid for the physical therapy that should have never been needed to start with. That is fee for service. So the way I take that and use it to my patient and employer's advantage is I go find the Davids of the world and send all our patients to the Davids. And if you will let me put the right plan design in there, I make it free for patients to go to David. And they have this $5,000 deductible, they have a copay, they have all this other stuff. If they want to go to Pete, they can go to Pete. I'm not going to tell them no, they can't, but they're going to pay for that privilege,
Right.
right, in the form of copays and deductibles. What we have proven mathematically and algorithmically, and what stop loss carriers have finally gone, if you control admits per thousand, if you control average length of stay, if you control level of care, if you control site of care, if you ensure the highest quality care from the highest quality providers, now fee for service is working to your advantage.
Right.
Get people healthier faster, they will file fewer claims.
So
Counterintuitive, but it works.
Right.
let's so as an employer, usually when I'm talking about making a change, one of the top questions is going to come up is who's my network? How big is the network? Right? Because everybody, I mean, if I'm an HR professional, I want to have the largest network out there because I want to make sure I have the least amount of people coming to my door, right? Then if I'm the CFO and the CEO, I want to be able to say I've got a BUCA, a Blue Cross United Healthcare Cigna, because they're household names, right? But then also if I'm a CFO, I'm probably also thinking that the PPOs have created a discount package, which is going to be advantageous to me. So can you tell us what your experience have been and kind of what your thoughts are around PPO networks and their value?
How to do that without cussing?
Don't
It's
get it out of you
okay.
one way or
You
another.
can cuss. We can bleep it out.
I know how. I know how.
I got in
Are you-
trouble when I was at a NABIP conference recently. I got pulled aside and they told me to settle down. And I'm like, what do you mean?
Oh,
They said, you gotta tone your language down. And I said, I just have an opinion that our healthcare delivery system is our communities of opportunity. And they said, maybe don't use the word.
you have to adopt my strategy then. Are you ready, Pete?
Let's hear it, Nurse.
Here's why I got in trouble. Are you familiar with a product called KY jelly?
Yes and no.
Because
Oh God, I know where this is going. I can't wait till you're live in a room with 100 employers.
I got in trouble because a broker told me that this customer would not leave the BUCA, the network. They couldn't get over this understanding that the network is not your friend, the BUCA is not your friend, that giving you 50% off of a 6,000% markup is not doing you any favors, right? And I
Right.
can't tell you how many conversations I had about that topic with this employer and this broker. So they decided they just couldn't do it. They couldn't do it. So I just sent them a case of KY and said, you're going to need this.
I love it.
Because
I
I
don't know
mean,
if we can get away with that, David.
Yeah. All
I
right,
mean, she's on
scratch
the
that one
clinical.
off.
Clearly, she already identified herself as the smartest one in the room because she's got, what was it, the statistics, the math. She's nurse. You know, I sell insurance. Those are reasons why I sell insurance.
yeah,
That's
but I
great.
mean, you've been doing the whole carrier BUCA network thing for, the US healthcare crisis started in 1960. That's before I was born.
Yeah.
So we've been doing this for the last 60 years. How's that working out for you?
Well, yeah, I think it's the opportunities of our communities, to be honest with you.
It absolutely
I
is.
mean, when you
And
see free healthcare or pop-up clinics in your own neighborhood and people are sleeping in their cars so that they can go in and see a doctor, I mean, it's disturbing. It happens here in Arizona. It's disturbing.
when we have single moms that are deciding between their medication and
Hmm.
their electric bill in the United States of America, it's unconscionable to me.
Right.
And we are where we are, how we got here, I could write you a dissertation thesis on it, right?
Right.
I could give you a PhD level explanation of it. It doesn't matter. The fact of the matter is we shouldn't be here. There is a way forward, there is a way out of it, but you have to think and behave differently.
Right.
So until there's this whole thing called Beckard change model, it essentially says that nobody undertakes change unless they are so dissatisfied with their current predicament that they are willing to take the first steps forward toward a better vision. I've given you the vision, right? We do free healthcare for our patients every day, all day long. We guide them to the best care from the best providers. That's how we afford to do it for free.
Right.
We've been doing it over and over and over and over again for more, right? I have enough gray hair to prove the years that we've been doing it. The Validation Institute publishes studies. It's proven that there's a solution.
So let's dig into that a little bit, because that's what David and I run into all the time, is for some reason it's still not painful enough. I mean, we know it's in the top 3 on their expenses. But I think it's just not painful enough because they're not quantifying it. They don't know. They don't understand that, if you have 1,000 life company, you could probably reduce your expenses by $1 million pretty easily, like without trying hard. And even if it's 100 life company, if you could, save $100,000 really without trying very hard, if we can quantify that. So, but you're 100% right, is we're very independent. We like to, our decisions are always the right ones. And so the resistance that we see is where I would like some of your guidance on, because a lot of it, number one, is the PPO. I have to have a PPO network that says a Blue Cross, United Healthcare, a Cigna, or an Aetna. And so,
Well, I hate to cut you off, but can I call bullshit on that for a minute?
well, this
Please,
is why I'm asking that
please.
question.
Go, go look at Adam Ruins Everything Healthcare.
Oh, I love that.
It's funny because it's true.
Yeah.
So me telling your patients that they can go anywhere they want to go because everybody's in the network is setting them up for failure, because in that PPO directory, you have A++ physicians,
Okay.
you have C- physicians, you
Okay.
have F-, physicians. I just did an analysis. We work a lot with direct primary care doctors.
Right.
And we asked direct primary care doctors, give me your list of specialists that you refer patients to. This doctor sent us a list of 29 specialists that he commonly refers to. 2 of those doctors had sanctions against their license. 9 were not board certified in their specialty. By the time I got done, I said to him, every single time you refer a patient out, there's a 50-50 shot that you're sending them to a good doctor versus a quack. To put that in perspective, as a patient, right? Trigger warning, literally. If you're playing Russian roulette, the chances of you losing on your first trigger pull are less than 17%.
Right.
But your chances of your primary care doctor sending you to the wrong doctor is 50%. This whole idea of a PPO directory, it has nothing to do with quality of practitioners, and it has nothing to do with the cost of care. Right? People all the time are like, well, this PPO is going to get me a 60% discount, and you want me to move to a PPO that's only going to give me a 40% discount. 60% off of what?
Right.
The average markup on chemotherapy across the country is 6,000%.
Wow.
Unless you're giving me 100% discount, I'm not saving money, right? And if we're going to take care of the human beings that are the end recipients of this care, do we not want to get them the highest quality care? Do
Absolutely.
we not want to get them that care in an affordable way?
Absolutely.
So I am so
But they don't know
over.
how. And I think that's kind of point two, is that they don't know what is available to them. Like, I mean, so AIM, how does your team find out what a reasonable cost is for either a drug or a treatment? Like, what tools do you have that you're able to access so that you can, present this information to a sponsor?
We currently license over 40 different quality and cost transparency tools
Okay.
because until I create it, there's no single consumer reports of healthcare.
Okay.
You can't just go Google, my wife needs tamoxifen for her breast cancer. How do I get it in a high quality, affordable way and get an answer?
Well, and I
It
don't
doesn't
think
exist.
the member isn't going to do that
They're
because the
not.
member knows that they have $5,000 out of their pocket and they don't really care what the cost of anything is because that's what they're focused on. I mean,
There
this has
is
to
no
be driven
price
by.
on a human life in the United States. When
Hmm.
I was in nursing school, we had a guest lecturer and he had a very thick accent, but I will never forget him saying, in my country, in my third world country, death it occurs all the time. In most non third world countries, death is inevitable. In America, death is optional. And we will spend any amount of money to get one more day with someone that we love,
Hmm.
right? So,
That's fair.
talking to patients about what care costs, especially in a catastrophic situation, they're going to blow through their out of pocket maximum. And the number of patients that I talk to that are like, I don't care what anything costs because every year I hit my $8,000 out of pocket max
Right.
for my family and I don't care,
Right.
right? The other point that you were talking about, Pete, this book over my shoulder, Life and Death Decisions in the C-Suite. I co-authored that book. It was born out of a level of frustration. And quite frankly, my mom did the Nestea plunge on the hardwood floor in my dining room the Monday after Thanksgiving in 2021. She had a traumatic multi-level spine fracture. I'm the creator of Call the Nurse,
Right.
get the highest quality care from the highest quality doctors, right? I created that whole thing. My son came into the ER and said, Mom, this surgeon that's going to operate on her spine, is he a genius or a quack? What's his quality score? And I was like, oh my God, I forgot to even call in and ask one of the nurses to look him up. When you're in the throes of that,
Yep.
when you are told your kid has a brain tumor, when you are told your spouse has 6 months to live tops, calling the nurse and getting in and looking at the math and looking at the science, that's not the first thing on your mind. Your
Mm-mm.
providers, however, are going to call your insurance company because they are a business and they're going to say, is this person effective and eligible? Do they have coverage for this? What are the rules that I have to follow to get coverage, to get
Right.
paid for this? If I'm doing the pre-serve, that's an early warning detection system for me that, hey, something's going on with Pete. I need to be helping him
Right.
right at that point of sickness. So that's when I can then step in and go, time out. This doctor is not a genius. We want to deflect this. We want to move this. Or this simple surgery that could be done anywhere, any one of 29 places with any one of 50 doctors. Let me go look at their objective scores. Let me go see what their outcomes are. Let me arm Pete with that information and help him make the best decision.
So you're really, yeah, I mean, you're figured out you're sitting on the same side of the table as the patient
And the employer
and the
who's
employer.
paying for their health care, right?
Right. Right.
Because
Checkbook
whether
and
you're
close.
fully insured or self-funded doesn't matter.
Right.
You're paying for the healthcare services that your employees are using. It's just, are you doing that through premium or are you doing that through funding the claims?
Right. So you're talking about, I mean, a few minutes ago, you talked about that behavioral economics of it, where you're waiving their out-of-pocket expenses, and that's where really where you're getting the buy-in for you. But let's look at what are your nurses' experiences when they're talking to a patient or a family member of a patient, and you're saying timeout. You don't want to see that doctor. And knowing that they probably got to that doctor through a relationship that they've had with another doctor. And so there's this line of trust that your nurse just said, I want a break. I would like to have you go see a different doctor. What are the reactions that they're getting? Is it going to going into a position of fear because, why are you telling me that my doctor's no good? I trust my doctor. He would never send me someplace that's not good. Or are there reactions of relief saying, I'm so glad you're on my side of the table so that I can just focus on healing myself or my loved one? Like, what are your experiences with that?
Yes, all of the above.
Okay.
And part of it is we've been doing this for over 10 years. We've been doing guided plans for 10 years,
Okay.
right? Where if you call the nurse first and you follow the nurse's guidance and advice, your care becomes free.
Right.
We like to give our patients alternatives, right? So we don't ever want to say, go to see Dr. David, don't go see Dr. Pete, right? We like to say, Dr. David has this quality score, Dr. Pete has this quality score, Dr. Sam, Dr. Joe, Dr. Mary, Dr. Susie. Here's your options, right?
Right.
We also use Prochaska method and motivational interviewing techniques in combination with Dale Carnegie strategies. So
Okay.
we are pretty confident that we have dialed in the talk track for having that conversation,
Okay.
right? There's an art to having a hard conversation with a patient. It's easier when they're incentivized by free care, but only about half of our customers make that available to their patients. The
Hmm.
other half, we're just appealing to the nobler motive of, hey, did you know this about your doctor?
Yeah.
Here's what and we often use if I were your best friend, I would raise some flags of caution, and here's why. Now, no harm, no foul. It's your decision. It's your body. You still have free will and autonomy. But did you know these things? And are you open to looking at somebody who doesn't have those concerns?
Right.
And when you incentivize patients, over 85% of the time, they will change. There's always
Well,
going to be
sure.
those couple that hold out, right? Um, and the other part of it is it depends on the severity of the health issue, right? If it is a routine primary care visit and you want me to switch from somebody who has 3 stars to somebody who has 5 stars, is that really worth it? Versus if we're talking about open heart surgery, I'm way more open and receptive to, I don't care where you send me. I don't care what my doctor said. I want the best of the best if they're going to crack my chest open,
Right.
right?
Yeah.
So there's some of that that plays into it too. But the fact of the matter is, most patients are open and receptive to at least having the conversation.
Yeah.
And then
Well, you're
if
giving them a chance that they never had before. And I think that's a key for an employer to understand because it really is changing their how their benefit plan is going to operate. Because I mean, we always talk about member engagement and we always talk about quality, but I mean, you mentioned that you have subscribed to 40 different quality control metric services. So what that tells me is there's not really anything that's available to the general public if they want to start looking for quality control metrics, right? I mean, that's just not
they
like
could try, but I mean, let's say it's a primary care doctor, something super simple, right?
right.
Number one, the objective case mix adjusted severity risk indexed objective scoring system is something we have to pay for. So they wouldn't be able to get that.
Okay.
They could, if they knew where they wanted to look, go see, does that doctor have board certification? They could, if they knew where to look, go see, does that doctor have sanctions against his license? They could, if they knew where to look, go see how much outside money does that doctor take? Is he on the pharmaceutical company's payroll or the prosthetic
Hmm.
device payroll? That's public information. They could find it if they wanted to go dig for it. They could Google him. They could see, is he dead? Is he retired? You know, does she have a good bedside manner? Do people say they love her? They hate her? I hate that measure because most patients wouldn't know quality if it walked up and smacked them in between the eyes.
Yeah,
You know,
for sure.
we joke about it in nursing and say, but did you die? Right?
Right.
I know he was you know, a very bad bedside manner, but your brain tumor's gone, right? So
I mean, do you care if your doctor's a jerk, if he's the best
They heal
around?
you. Yeah.
Like you mentioned, like when we were on another call, there was only like 5 doctors in the nation that have an 80% success rate of a procedure, and all the other doctors have like a 20% rate of success. I mean, do you care if that doctor's got good bedside manners?
do you care if
I
he's a
mean,
jerk? I wouldn't care. I'll be like, be mean all you want, man.
Fix me. Yeah.
yeah,
Right?
and it's also very emotional metric because I mean, I have a lot of physicians in my practice, and they're trained now just to go in and say hi and just talk to the person, and then like take their temperature or put the stethoscope on them, because if they don't, and they're not taking notes because it's already done. I mean, it's already in the chart, but they're only doing that so that the patient feels like they got seen by the doctor, and then they get a better review.
Yeah.
It's just this perception, which is kind of interesting. So I agree that's probably not making sense.
Nurse Deb,
Um,
oh, sorry, Pete.
you guys question. Hang
I
on,
just had a
let
quick
me close the
question.
door.
Like, so you're looking at qualitative data, right? Are you looking at types of therapies at all? And I asked this because I'm dealing with it with my mother currently. Um, we're trying to get through to her employer to look at their health plan. They're kind of just staying with, the Bucas, excuse me, a nonprofit in Connecticut. And in the meantime, she had a recurrence of breast cancer. And so now I'm in this right now of trying to figure out of her 6 doctors that she has for various things, who are the good ones and what type of therapies are they going to do, right? But immediately they're going to do chemo and surgery, right? That's what they want to do. Do you look at types of therapies for these physicians to kind of steer people towards, like, and I guess I'll elaborate a little bit because I think there's an underlying issue, maybe like Lyme disease or something that may be affecting her immune system, but doctors aren't looking at that. They're just like, we want to do the surgery for your cancer first, and then we'll get to your immune system. So does that make sense?
It does.
Okay.
I mean, she's living the typical American experience. And to Pete's earlier question, how do we get customers, employers to understand the importance of this? I would say, the only thing that your population, your employees hate more than your insurance is cable companies. And we see what they did to them. They cut the cord, right?
Yeah.
Yeah,
Your employees already hate your insurance because they're having problems exactly like what you're describing, David. And there is nobody in the traditional status quo system for them to turn to and go, hey, this is what's going on. Help me. Right.
Mhm.
So the employers, and I think you and I were on a call the other day, Pete, where somebody mentioned they had a health issue, and I'm like on it. Like, did you look at this? Did you ask this
Right.
question? Have you,
right,
you know, those are the employers when they finally personally feel what your employees are feeling,
right,
their whole attitude changes. It's unfortunate that we have to let it get to that.
Right.
Most company owners, let's face it, majority of companies in the United States are small businesses,
hmm,
right, with a very small ownership leadership structure. And those folks, I know, I lived it. I've spent the last 30 years leading a company, as a solopreneur, like a family business, right? You're so wrapped up in manufacturing your widgets that you don't have the time, effort, or energy to focus on anything else. But if your spouse or your child has a health event and you live through the
Right.
mess that we call US healthcare, you will the next day go, this insurance thing, it stinks, and I want to replace it. If all of my employees are experiencing what I just experienced, I want to change it. Unfortunately, they're so focused on doing what they're doing that they'll ignore their own health, and so they never have that horrible experience.
right,
Understand though that this whole concept of objective scoring for physicians, facilities, practitioners, healthcare providers, it is still very much in its infancy. I love science. I love math. I believe the algorithms are strong. The ones we license are strong. I will tell you, I get numerous calls a week. Hey, look at this new quality tool. Buy it from us. And I get into it, and it's not case mix adjusted. It's not severity risk index. It's not based on objective data. It's just a fancy Yelp or Angie's List. And I'm like, I'm not interested in that, right? But the whole thing is still so much in its infancy that this is why, David, your mom's case is a perfect example of why technology, even AI, even as advanced as it is, cannot currently solve that problem. You've got to get a clinician, and this is where a lot of my competitors miss the boat. They try and use these non-clinicians for very intimate clinical situations. And so I would say to your mom, if you have a history of Lyme disease, which already makes you immunocompromised, and we're talking about putting you under the knife for surgical intervention, I worry about that.
Right.
I super worry about putting you on an immunosuppressant that's chemotherapy, right? So I'm going to want to really dig in, and I want a copy of your pathology report. I want to know your stage, your cell type. I want to know who's doing the latest research on that stage and cell type. How can I get you out of the, butcher counter, now
Yeah.
calling number 10
Yep.
system, and get you to somebody who's highly specialized, who's actually going to review your medical records, consider your prior comorbid conditions, your other conditions, who's actually going to spend an hour going through all this and going, okay, given all of these nuances, here's our best treatment path forward. Let me go confer with some of my colleagues who specialize in Lyme, who specialize in radiation, who specialize in surgery. And you don't just Google that doctor and find them. You've
Right.
got to have somebody to come alongside you and help you through those challenges.
Right.
So
Yeah, she got the positive cancer test, and they sent her straight to the surgeon.
right.
She was
And
like, "Can
that
I talk
might
to
be
my
right.
oncologist?" She's like, "Can I talk to my oncologist?" And they're like, "Surgery."
And that might be right.
Right.
It could be,
Mm-hmm.
but she has nobody to turn to and go, is this right?
Exactly.
Yep. And that's exactly what we experienced on that last meeting with
Mm-hmm.
that 1 in 8 doctors that you were talking about. Some stuff that David and I have been exposed to has been like the hidden cost of digestive orders, where it's kind of just being masked as other things. Do you have any data on like how that is impacting the workforce?
Yes, but I would tell you that you're picking up the penny while you're overlooking the pound.
Okay.
Um, I mean, let me back up. We do claims data mining on all of our customers. We won't bring you on as a customer if you won't let us do claims data mining, unless you're fully insured, but that's a whole nother thing,
Yeah, that's a
right?
whole nother ball of wax.
Yeah, yeah. Um, so we do claims data mining on all of our customers. I have customers all the time who come to me and go, we're worried about gastrointestinal health because we saw a study or a commercial or a whatever. And I go, really? Because when I look at your data, I'm worried about musculoskeletal problems.
Mm.
I'm worried about diabetes. I'm worried about these two hemophiliac twins that you have on your plan, right? To me, GI is way down at the bottom of the pecking order of something I'm going to be worried about. I'm worried about all of these women who haven't gotten any mammogram at all. I'm worried about the flu shot compliance rate. I mean, so to me, yes, I'm aware of that issue. Yes, we've studied that issue. Yes, we've got experts to address that issue. Is that an issue you ought to even be worried about? Until I analyze your population, this is why I don't go out and sell diabetes disease management programs. because everybody thinks they need diabetes disease management because they've seen it and they've heard it, and everybody knows a diabetic. If you are a municipality and you're covering firefighters, you probably don't need a diabetes disease management program. They're young, they're male, they're healthy, they're not obese, they're look at your population
Right.
and
Yeah.
figure out what you need. The other thing I will tell you is I love population health. It makes sense in many scenarios. It does not make sense in scenarios where you have high turnover, because all you're doing is making that person healthy to go to work for your competitor, because that's where they're going when they leave you, right?
Yeah.
So you've got to understand the nuances within a particular group.
I bet that person won't leave for the competitor if they have $0 healthcare costs.
Very true,
Yeah.
right? The other thing is one person deserves one person's attention and care. So if you've got one person on your plan who's having a problem with GI issues, I don't need to offer help to your entire population around GI issues. I need to help that one person or those 5 people or those 10 people, right? That's where this whole idea of patient-centered comprehensive care management comes in. What are your comorbid conditions? What are your socioeconomic situations? What's your education level? What are your personal beliefs and philosophies? I talk to women all the time who say, I didn't get a mammogram and I'm never going to get a mammogram. And I go, why? And they go, because even if I got breast cancer, I'm never going to get my boob cut off. I'm never going to undergo chemotherapy. I'm just never going to get the treatment. So why would I go get the test?
Right.
And I as a nurse can go, I understand and I respect that. And everybody has a right to make the decision that's right for them, you know? Um, but I still want to have the conversation. I still want to be a resource. I still want to be a support.
Right. Well, you want to give them information so they can then have a basis of education and decision.
Hey,
Right.
if I tell you that grapes are cheaper at Meijer than they are at Walmart, and you're not in the market for grapes, what do you care?
Right.
Right? If I come along with that information at the right time, when you're getting ready to make a bottle of wine, maybe you care.
Maybe you
Yeah.
care. Although I don't know if you're making wine from the grapes at Myers, but that'll be a different conversation.
I didn't say good wine, Pete.
So we talk a lot about financial wellness, and we've touched on the periphery of it for pretty much this entire conversation. So clearly the members are being impacted from a financial wellness because they're getting their out-of-pockets waived. And we all know that's important because what's the statistics? Like 73% of our population can't afford a $500 bill. And
Right.
when our out-of-pockets are averaging $5,000 in the nation, that number goes up to something like 92% of the people can't. So we know we're improving their financial wellness. We talked about the financial wellness of the plan sponsor because, outside of what the employee's paying, the plan's paying the balance. So if we can control that dollar. So what about the industry? So I mean, and I'm really being careful in how I word this, but if you're able to get somebody into a hospital system and you're paying a fraction of what they would be getting from a PPO network, like what experience are you seeing from the industry as far as having someone like yourself involved, working with the patients, negotiating different fee for services, direct contracts? I mean, are they also benefiting in some way as well?
Believe it or not, over and over and over again, we find that providers love what we're doing. And
Okay.
it sounds counterintuitive. Now, I will tell you, the ones that are, up to no good don't love it.
Sure.
The ones that are F minus minus quality scores don't love it.
Well, yeah, because you're not sending anybody there, so their benefits are going
Yeah.
down.
No.
So I get that.
Yeah.
I'm not sure I care whether they love it or not. But when providers get a patient that comes in the door and that coverage is paying them at 100% of a fair and reasonable price,
Right.
and they don't have to collect money from a patient,
Right.
and they don't have to fill out a bunch of paperwork, and they don't have to hire a debt collection agency to go chase them down.
Right.
It cuts out all of that crap they don't want to deal with anyway.
Right.
And the number, remember
Their
we're,
margins, I'm suspecting their margins are going up.
yeah, I would suspect as well, right? The other part of it is, remember, we're a patient facing model.
Right.
So patients call us and tell us, I need blah, 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 blah. And we ask them all kinds of questions, and we're doing the pre-certification with the patient. So by the time the provider ever calls, yeah, it's already done.
Right.
They're like, what, how, who, where, I didn't tell you you don't need to tell me anything. I already got it. And they're like, oh, okay. And oh, by the way, you're going to get paid at 100% of the direct contracted rate. You don't need to collect copay and deductible.
Right.
They're like, did I just get sucked into the twilight zone? Right? What's going on?
So,
They love
so,
it.
so it's
Providers
not a
love it.
contentious relationship. I think that's kind of where I was going to, is that
No.
everybody, it really is a win-win-win situation, because we're passing benefits to the member, passing benefits to the employer, and also passing benefits to the facilities. And so really, I mean, if you're putting a bow on it, you're giving people tools so that they can make the better decisions for the right place, the right time, the right cost, you know.
Hey, now that's trademarked, getting the right patient, the right care at the right time in the right place for the
I
right
didn't say it in
price.
that order.
Great trademark though. Yep.
Derivative works, Peter.
It does. This has been very helpful. Did we miss anything? Is there any, because we're up at about an hour, so I want to be respectful of your time. Is
No,
there
I
anything
mean,
that you think we didn't cover that you'd want to make sure folks hear?
no, I would just say for the employers out there, if you truly love the lifeblood of your organization, which is your people, you've got to get them out of this system where today they're being butchered, maimed, and killed, and you're spending a whole lot of money for it. That's not helping you. It's not helping your business. It's not helping your employees. And the current state of the US healthcare system, people ask me all the time, Deb, what happens to you and your company if nationalized healthcare happens? I'm like, oh man, I am going to be like rolling in cash. And they're like, what? I'm like, yeah, because I instantly pivot to being the coyote of the US healthcare black market, because I know who all the best doctors are. I know how much money they want in cash to take care of patients. You need a gallbladder out? I got you, man. Right? I can get you that in the next week at a fair and reasonable cash price. So the solution is there.
I'm not sure how to spin that.
Right? But the solution is there. It's just we need the employers who are so focused today on their widgets to
Yeah.
back up for a second, take a breath, look at what's actually happening, and be courageous enough to do something different before it happens to you and your family.
So, and
Yeah.
we're going to go over because I just got three more questions in my brain. Sorry. So is there an opportunity where somebody listening to this can say, you know what, I'd like to have someone peek under the hood? So I'm assuming, is there an opportunity that if we can get claims data, or if we can get the right amount of data, that you can have a review of it to start kind of
Nope.
picking apart things? Nope.
Yes and no. So what I would tell you is we're in the throes of fourth quarter and we're growing astronomically.
Yeah.
So if you want to hop on a call with me and run a scenario by me, I'm happy to give you my kind of off the cuff. If
All
you
right.
want me to do an actual claims data dump and analysis of your claims data,
Yep.
number one, I'm going to charge you for that.
Sure. As you should. There's
And
value there. So you absolutely should charge for that.
And number two, getting your claims data, getting it through the system and getting it analyzed is going to take an absolute best case scenario 30 days. I would tell you, you ain't got that kind of time.
Yeah.
It's crazy. You know what's broken.
Well,
You've
we
seen
would be
it
doing
delivered.
this for probably second quarter. This is well, it might be end of first quarter on a push.
Here's the simple answer, Pete. Take what you're paying for healthcare,
Okay.
divide it by the number of employee lives that you have on your health plan.
Okay.
If that number comes out higher than $6,000 PEPY, you must call and call today.
Okay.
There is no way that your plan should be performing that high. Now, keep in mind the national average is between 15 and 18,000, depending on who you ask.
Wow.
If you're an employer who's already under 6,000 PEPY, then you've at least already done something, even if it's just living on a wing and a prayer with a lot of hope, but you're
Yeah.
already doing something that is okay.
Is it PEPY or PM? I mean,
PEPY.
okay, per employee per year.
Yep.
Okay.
So that
Because you
number, if
said
you're
all
over
belly buttons, and so that's right. You're talking about just subscribers, not the dependents.
just the employee lives that are on the plan,
Perfect.
dependents fall under that by, their money counts, right? Their
Right.
expenditures count. But
We use
Milliman,
that tool.
the actuaries publish PEPY. Kaiser Family Foundation publishes PEPY, right? So that's kind of the benchmark. But if you're over 6,000 PEPY, you are overspending and harm is being done in the process.
Okay.
You need to do something different. If you want to
Okay.
get into the nuts and bolts and specifics of it, yes, that can be done. We can look at your population. We can do an in-depth analysis. We've got everything from fill in your admits per thousand and your average length of stay and your number of maternity cases and your number of ER visits and plug it into this tool and we'll give you a 15-page PowerPoint that tells you where you're off, right? Where your numbers are off. Um, but honestly, I don't think anybody in America has enough time to mess around with that
Yeah.
kind of turnaround time.
No, that was very helpful. And then I think the last thing I would like to wrap up. So if we have employers that are working with you, and they're in this model, clearly they're going to start saving money, right? Their costs are going to go down. Does an employer change their mindset at some point from like, oh, how am I going to pay for this expense to what can I do next for my employees? Because now I have an extra million. Not they probably don't have an extra $1 million because they're going to reinvest it in their firm. So I get that. But let's take a portion of the savings and let's see what we can provide from a wellness perspective. Like, do you see a shift in kind of how employers are thinking about care or
My
just
longest,
benefits?
yeah, my longest standing customers that are in guided care have done all kinds of things. So they might start off with a premium holiday, right? Get
Right,
around October, November, December. We're going to not take a deduction out of your paycheck this month so you can
right,
spend a little extra for Christmas. Um, Very quickly, if they continue to fund at their pre-AIM levels, they're pretty quickly going to establish a pretty significant nest egg. They start covering infertility treatment. They start covering doulas and birthing centers. That's a smart use of that money. They
Okay.
start paying for 6 massages a year, no questions asked. They
right,
start covering chiropractic care, 12 visits a year, no questions asked. They, build a walking track around the campus. The ones that have been with me the longest now offer zero premium employee only health insurance. So the day you walk in and you get hired and you fill out your new hire paperwork, you're automatically enrolled in the employee only health plan. It costs you zero.
Hmm.
If you call the nurse first and follow the nurse's guidance and advice, you have no copay, no deductible,
you have a
right?
100% plan.
You have 100% coverage for the employee. Most of the plans that have been doing this a long time are covering anywhere from 60 to 80% of the family premium. I have one that's covering families for free.
Wow.
You and your family have no premium health insurance, right? So there's
Right.
all kinds of creative things that you can do that are going to improve your recruitment, improve your retention,
Yeah.
right? You get out of that vicious cycle into a positive cycle. And like you said earlier, we had a law firm, 100 employee lives on the plan. there were these three gals who were long tenured employees, very high in the organization, very influential. Think like law partner, executive assistant level kind of people, right? And one of them had her OBGYN for 20 plus years, loved the OBGYN. The OBGYN had sanctions against their license. And she was furious that we would not cover that practitioner at the guided level to make her going for that care free. We had another whose pediatrician had 3 kids. This is our pediatrician. We're going to go to this pediatrician. And that doctor's quality score was not in the top 20th percentile. And we said, no harm, no foul. Keep going to that pediatrician. Just pay your deductible and copay like you always have. She was furious that we would not make an exception and put that doctor as guide. There were these 3 gals, right? So they got to their 9-month renewal, and the practice owner came in and said, I'm really sick and tired of hearing these individuals throw a fit. They're very, very, very noisy about this. They don't like it, right? So he called an all hands meeting and he put them all in a room and he said, it's time for us to decide what we're going to do about health insurance next year. We've done this for a year. We've heard a lot about it. Do we want to continue with this, or do we want to go back to a more traditional health insurance? And these 3 women jumped right up about why this is bad and blah, blah, blah. After that, a woman got up and talked about how her husband's prostate cancer had been cured for free. A gentleman got up and talked about how his child with cystic fibrosis had been needing a compression vest for the percussion vest for the last 5 years, and none of the insurances had ever covered it. And well, this insurance doesn't cover it either, but the nurse helped me get into the Cystic Fibrosis Foundation and got us that vest for free, not through the plan, but through a community resource. And then a young lady got up and talked about how she had planned to go to this doctor for her gallbladder surgery. And the nurse had called her and kind of waved her off and said, danger, danger. You might want to look over here. And she was only out of work 3 days when she got her gallbladder done, and how appreciative she was and how it cost her nothing. And person after person after person got up and said, here's what it's done for me. So he finally said, okay, I think it's time for us to take a vote. Who wants to stick with what we're doing? And all of the hands in the room except 3 went up. You're never going to make 100% of the people happy 100% of the time. Some people want what they want, and they are entitled to.
That might be trademarked too somewhere.
Right? Probably. But yeah, I mean, are 100% going to be happy? No. I mean, there's no way. If you're going to a doctor who has sanctions against their license, I am not going to go to the health plan sponsors and the stop loss carriers and justify paying that doctor at 100%.
Right.
I can't. I won't. It's not going to happen.
That's not also why we're contracting you as well. We want you to make those decisions, because it's hard for us to make these decisions because we don't have the information.
Yeah. And it's hard for your patients to make the decision because they don't have the information either.
Right.
Right now, it's just,
they're manufacturing a widget. Yeah. Well, cool. It's been very helpful. I appreciate your time. Sorry for going over 12 minutes.
Yeah, sorry.
Because it is fourth quarter and it's busy.
Hey, busy is now a word that causes a $5 contribution to the cuss jar at our company.
Really? Good for you.
Everybody is busy.
Yeah.
Yes, we are.
That's
all right.
Yeah. Talk about recruiting and retention though, right?
That's really what it is. And well, it's a better way to treat our employees.
Yeah.
We're always chasing for the lowest dollar, but we don't pay attention to the lowest dollar. I'll trademark that one.
Yeah, that's a good one, Pete.
And my 100 cents on the dollar one.
What drives me crazy is you have supply chain management gurus, especially in the larger organizations.
Oh, yeah.
who will beat a vendor up over a third of a penny on a paperclip.
Yep.
Yeah.
But you're not looking at your number 2 or number 3 most expensive line item and going, are we getting our money's worth out of this? It's not even, you know what? I do not know an employer on the planet who would begrudge spending $25,000 per employee per year if they knew that their people were getting world-class, phenomenal health care. But let's look at the facts. We die faster and more in debt than anybody else in the civilized planet, right? Any other civilized, industrialized country. What we're doing doesn't work. I mean,
Well, it
I as
works
an
for a few of
employer,
us.
yeah, I mean, my team is extraordinarily valuable to me. I wouldn't care how much health insurance cost if I was confident that they're getting the best care from the best doctors, they're healed quickly, they're back to work, they're happy, they're productive, they're present. But the fact of the matter is, that's not what's happening in the traditional system.
No, misaligned interests. All right.
Well, it was fun, Pete.
It was fun. I appreciate it.